تمام. Our seminar today is about bones of the lower femur. The femur is the longest and strongest bone of the body. It's composed of head, neck, shaft, and expanded lower end. The head is more than half of a sphere and is directed upward, medially, and forward. It is intra-articular and covered with cartilage apart from a central pit called the fovea capitis, where the ligamentum teres attached. The neck, 5 cm long, forms angle with the shaft 125° in females to 130 in males. It's anteverted at an angle of about 10° in adult with the sagittal plane. The greater trochanter is the superior junction of the head and neck. The lesser trochanter is the inferior and slightly posterior junction of the head and neck. Between the greater and lesser trochanters anteriorly is a ridge called the intertrochanteric line, and posteriorly a more prominent intertrochanteric crest. The shaft is inclined medially so that the lower ends at the knees almost touch. The shaft is cylindrical with a prominent ridge posteriorly called the linea aspera. The linea aspera splits inferiorly into medial and lateral supracondylar lines with the popliteal surface between them. The lower end is expanded into two prominent condyles united anteriorly as the patellar surface. So you have the patellar surface anteriorly, but separated posteriorly by a deep intercondylar notch. The most prominent parts of each condyle are called the medial and lateral epicondyles. So here we have the head and the fovea capitis for the attachment of ligamentum teres. We have the neck anteverted anteriorly 10 degrees and greater trochanter superiorly, lesser trochanter inferiorly, inferior-posterior, and anteriorly we have the intertrochanteric line between greater and lesser trochanter, and posteriorly intertrochanteric crest between the greater and lesser trochanter. And at the distal end, we have the medial and lateral epicondyles and medial and lateral condyles, patellar surface anteriorly, and intertrochanteric notch posteriorly, or popliteal fossa or popliteal surface. Here also we have an X-ray of the hip, AP X-ray of the hip, showing the head of the femur, fovea, neck, and the greater and lesser trochanter and intertrochanteric crest. AP X-ray of the knee, showing the patella anteriorly, medial and lateral epicondyles, medial and lateral condyles of the femur, intertrochanteric notch, ossification of the femur. The primary center appears in the shaft in the 7th fetal week. There is 4 secondary centers. In the lower femur appears at birth. This is a reliable indicator that the fetus is full term. In the head appears between 6 months and 1 year of age. In the greater trochanter appears at 4 years of age. And in the lesser trochanter appears at 8 years of age. All fuses at 18 to 20 years of age. The fibula is a sesamoid bone frequently seen in the lateral head of the gastrocnemius muscle. On radiographs, this is projected on the posterior aspect of the lateral femoral condyle. This is a normal variant, fibula. Blood supply of the femur. Vessels in the cancellous bone from the shaft, vessels in the capsule of the hip joint, which reach the head in the synovial folds along the neck, vessels in the ligamentum teres via the fovea. Main blood supply is via the neck from the capsule, thus fracture of the neck or disruption of the capsule during childhood, secondary to joint infusion, result in ischemic necrosis of the head in 80% of cases. So main blood supply to the femur is from the neck. Plain radiograph. Important lines. Klein line, a line along the upper margin of the neck of the femur, transects the femoral head in AP and lateral radiographs. This alignment is changed when the epiphysis is slipped. So here we are, the Klein line through the upper border of the neck and transecting the head. Here we see through the upper border of the neck, but not transecting the head. So here we have slipped capital femoral epiphysis, as we see here in the radiograph. This is normal, transecting the head, and this is abnormal. Line along the inferior margin of the neck of the femur forms a continuous arc with the superior and medial margins of the obturator foramen of the pelvis, known as Shenton's line, is disrupted in the congenital dislocation of the hip. So here we have Shenton's line, hip X-ray, normal AP. Shenton's line is formed by the medial border of the femoral neck and the inferior edge of the superior pubic ramus. Loss of contour of Shenton's line is a sign of fractured neck of femur. Important note, fracture of the femoral neck do not always cause loss of Shenton's line. Here we have loss of Shenton's line, bone overlapping from the fracture of the neck, short femoral neck. Here also disrupt Shenton's line. Special views. Femoral neck anteversion. The neck of the femur is anteverted approximately 10 degrees. In AP radiography of the neck, the leg must be internally rotated 10 degrees to position the neck of the femur parallel to the beam or to the field. CT scan, an angle is created between the long axis of the femoral neck and a line drawn between the posterior margin of the two femoral condyles. This is a line through the lowermost part of the femoral condyles and a line through the longitudinal axis of the neck. Angle of anteversion, called angle of anteversion. In childhood, it's about 30 degrees, but it decreases in adults. Lateral view of the neck, the film placed vertically and pressed into the patient's side must be positioned at angle of 127 to the shaft of the femur because the angulation of the neck to the shaft. Tunnel or notch views are views of the intercondylar fossa which are taken with the knee flexed at an angle of about 135 with a vertical beam and with a beam angle at 40 to 70 degrees to the lower leg. This is the angle between the neck and the shaft. Normally, it's between 125 130. This is normal. In coxa vulga, the angle is greater than 140, and in coxa vara, the angle is less than 125. This is a radiograph of coxa vulga, loss of the angle, increase the angle. Here also, coxa vara and coxa vulga. This is the tunnel view or intercondylar notch. The knee is flexed and the beam is angulated. It's important to know that only 30% of bone in the femoral neck is cancellous or metabolically active, in contrast to 50% in the vertebral body. This factor accounts for the detection of the osteoporotic changes in the spinal vertebral body before the femoral neck on DEXA scanning in most cases. The patella, sesamoid bone in the quadriceps tendon that tenuous at its apex are the ligamentum patellae. The upper two-thirds of the posterior surface is covered with articular cartilage and is entirely within the knee joint, and its anterior surface is covered by the prepatellar bursa. The lateral articular surface is usually larger than the medial surface. Here we have the patella in the quadriceps tendon. Posteriorly, we have the articular cartilage, and it's located within the knee joint. Lateral dislocation of the patella is more common than the medial dislocation and occurs following valgus injury with associated posting of the extensor mechanisms over the knee joint. Anatomical structures have evolved to prevent dislocation, including relative hypertrophy of the vastus medialis muscle and overgrowth of the lateral femoral condyle. Ossification of the patella begins at 3 years and is completed by puberty. Shapes of patella. Weber describes 3 shapes of patella. Type 1, the medial and lateral articular facets of patella are equal in size and dimension. Type 2, the lateral facet is slightly larger than the medial facet. In type 3, the lateral facet is dominant and the medial facet is atretic and redundant. In type 3 configuration is more commonly associated with tracking disorder and transient subluxation. Here we have medial and lateral are equal. Here the lateral is larger. Here the medial is atretic, as we see in the X-ray. The medial is atretic in type 3. Plain radiograph of patella. Skyline view, inferior superior axial projection, the beam centered on the patellofemoral joint from below. Used for assessment of patellar fracture, subluxation, and patellofemoral joint diseases. Merchant view, superior inferior axial projection, used for assessment of patellar fracture, subluxation, and patellofemoral joint disease, ideal for patients. So merchant view is ideal for patients in supine position. Here we have the skyline view, Laurin view, inferior superior projection, showing the patella. And this is the merchant view, superior inferior projection, and the patient in the supine position. The outer surface of the patella is irregular owing to the entry of the nutrient vessels. Bipartite patella, the upper outer segment of the patella is separated from the remainder of the bone and must be recognized as normal and not fractured. The synchondrosis between the bipartite patella fragment and the body of the patella allows minimal movement, which may lead to local inflammation at this site. And so, although bipartite patella is a normal variant, it is also a recognized cause of anterior knee pain. Have an X-ray of bipartite patella, mostly in the upper outer part. Bipartite patella. Tibia. The tibia, we have tibial plateau, the upper end, the upper expanded end, which has articular surface, large medial condyle, smaller lateral condyle. They articulate with the condyles of the femur. Intercondylar eminence or tibial spine between the condyles, which has medial and lateral projection, the medial and lateral intercondylar tubercles. The shaft, tibial tuberosity anteriorly at the upper end of the shaft of the tibia into which ligamentum patellae is inserted. The anteromedial surface of the shaft of the tibia is subcutaneous. The posterior surface of the shaft has a prominent oblique ridge called soleal line. The lower end of the tibia has the medial malleolus medially, the fibular notch for the inferior tibiofibular joint laterally. Its inferior surface is flattened and articulates with the talus in the ankle joint. Ossification of the tibia. The primary ossification center for the shaft of the tibia appears in the 7th fetal week. A secondary ossification center is present in the upper end at the birth and in the lower end at 2 years. The upper center fuses with the shaft at 20 years, the lower sooner at 18 years. The fibula is mainly a site of origin of muscles and has no weight-bearing function. It has head with a styloid process into which the biceps femoris is inserted, neck, narrow shaft, lateral malleus, lower expanded end. Proximal and distal tibiofibular joints unite it with the tibia, articulates with the talus in the ankle joint. The lateral malleus is more distal than the medial malleus. The calcaneofibular ligament is attached to its tip. This may be damaged in inversion injuries of the ankle. The fibula is proportionately thicker in children than in adults. So here we have the tibial condyles, intercondylar eminence, and the proximal tibiofibular joint, head of fibula. This part, upper part of the tibia called tibial plateau. This is tibial tuberosity for the patellar tendon. Medial and lateral malleoli. Lateral malleoli is more distal than the medial malleoli, and distal tibiofibular joint. Radiological feature, the tibial tuberosity is very variable in appearance, particularly during the growth period. Asymmetry and irregularity on radiographs may be quite normal. Some irregularity of the tibia at the upper end may simulate a periosteal reaction. This X-ray showing the medial and lateral tibial condyles, intercondylar eminence, tibial tuberosity, and proximal tibiofibular joint, head of fibula. This is a sesamoid bone in the knee joint. These examples on the tibial fracture, tibial plateau fracture, and distal shaft fracture. In adulthood, the tibia is characterized by thick cortex in the diaphysis, in contrast to thin cortex in metaphysis. So we have thin cortex in the metaphysis. Biochemical integrity of the tibial metaphysis is provided by an additional internal trabecular network, cancellous bony matrix, reflecting a lack of cancellous matrix and vascular supply. Healing of distal tibial shaft fracture is often delayed and so requires stabilization, internal fixation, and bone grafting. Bones of the foot. We have 7 tarsal bones: talus, calcaneus, navicular, cuboid, and 3 cuneiforms. We have metatarsals and phalanges. So we have talus, calcaneus, navicular, and 3 cuneiform, and we have metatarsals and phalanges. Talus, its long axis pointed forward and medially, composed of body between the malleoli with a superior articular surface called the trochlear surface. Neck grooved inferiorly as the sulcus tali, which with the sulcus calcanei forms the sinus tarsi. Head anteriorly that articulates with the navicular bone. Posterior process which sometimes separate as os trigonum. The inferior surface of the talus has large posterior talocalcaneal facet for articulation with the calcaneus, middle talocalcaneal facet for the sustentaculum cali of the calcaneus, facet for the plantar ligament, and the anterior talocalcaneal facet. The talus has no muscular attachments. Here we have talus, articular surface. This is articular surface for distal tibia, articular surface of lateral malleolus, and articular surface of the medial malleolus. And also we have this is the body. We have the neck, the head for articulation for the navicular bone. We have sulcus tali with the sulcus calcanei form sinus tarsi. And inferiorly we have anterior facet and posterior facet and medial facet for articulation with the calcaneum. And posteriorly, we have posterior process, which have medial and lateral tubercles, sometimes separate as os trigonum. Shepherd fracture. Fracture of the posterior talar process may occur following acute ankle trauma and lead to posterior ankle impingement and pain. This fracture is often overlooked or misinterpreted as being os trigonum. Lateral X-ray of the foot showing shepherd fracture and lateral X-ray of the foot showing os trigonum. Calcaneum. Largest tarsal bone lies under the talus with its long axis pointed forward and lateral. Calcaneum pointed forward and medially. It's cuboidal in shape. It has a shelf-like process anteromedially to support the talus, known as the sustentaculum tali. The upper surface has three facets. We said talus inferior surface has three facets for articulation with calcaneum. So in the calcaneum, in the upper surface, we have three facets for articulation with the talus. Middle one is on the superior surface of the sustentaculum tali, which corresponds with the facet under the talus. The plantar surface has a large calcaneal tuberosity posteriorly, which has medial and lateral tubercles. There is a small peroneal tubercle on the lateral surface. So in the upper surface, we have the anterior, middle, and posterior facets for articulation with the talus. This is the peroneal tubercle, and this is the calcaneal tuberosity, which have lateral process and medial process. Also, this X-ray showing calcaneal tuberosity and talocalcaneal joint, calcaneocuboidal joint, ossification of the tarsal bones. The tarsal bones ossify from one center except the calcaneus. The calcaneus and talus ossify in the 6 fetal months. The cuboid is ossified at birth. The cuneiform and navicular ossify between 1 and 3 years of age. The secondary center of calcaneus ossifies as 5 years. It fuses at puberty. The navicular may ossify from many ossification centers. This should not be confused with the fragmentation of the osteochondrosis or with fracture. Similarly, the epiphysis at the base of the proximal phalanx of the hallux may be bipartite in normal foot. Tarsal collision. Abnormal fusion between two or more tarsal bones and is a frequent cause of foot and ankle pain. Collision results from abnormal differentiation and segmentation of primitive mesenchyme, preventing the development of a normal joint. Approximately 90% of tarsal collision involve the talocalcaneal or calcaneonavicular joints with either fibrous, cartilaginous, or osseous bridging. Pain develops in the second decade as bone growth is impaired and the abnormal segment becomes mineralized. Calcaneonavicular collision and talocalcaneal collision. Arches of the foot. Longitudinal arch in the sagittal plane more pronounced medially. Longitudinal arch composed of two arches, medial longitudinal arch and lateral longitudinal arch. The medial formed by the calcaneus, talus, the three cuneiforms, and the first three metatarsal bones. Lateral one formed by the calcaneus, the cuboid, and the fourth and fifth metatarsals. The transverse arch in the coronal plane formed by the three cuneiforms, the cuboid, and the basis of the 5 metatarsals. Here we have the medial longitudinal arch, calcaneus, talus, cuneiforms, and the metatarsals. Lateral longitudinal arch through the calcaneus and cuboid and the fourth and fifth metatarsals. And the transverse arch the cuneiform through the cuneiforms, cuboid, and the 5 metatarsal bases. Medial longitudinal arch angle is the angle between a line along the inferior border of the calcaneal inclination axis and a line along the inferior border of the first metatarsal on the lateral foot X-ray. Normally measures 150 to 170 degrees. An angle less than 150 degrees is a marker of pes cavus, and an angle more than 170 degrees is termed pes planus, and in the acquired form is usually a marker of disruption of the plantar fascial aponeurosis or disruption of the tibialis posterior tendon. Calcaneal inclination angle used to assess medial arch height. The angle formed between the line along the inferior border of the calcaneum and the supporting horizontal surface. Normal range is between 18 to 30, less than 18 indicates pes planus and more than 30 indicates pes cavus. Here we have medial longitudinal arch angle. This is the angle, medial longitudinal arch angle, and here we have the calcaneal inclination angle. This radiograph shows pes cavus and pes planus. Sesamoid bones of the foot. Two sesamoids are found in the tendon of flexor hallucis brevis at the base of the metatarsophalangeal joint of the hallux. Sesamoid bones are often found at other metatarsophalangeal joints or at the interphalangeal joints of the first and second toes. Os trigonum posterior to the talus. Os vesalineum at the base of the fifth metatarsal. Os peroneum between the cuboid and the base of the fifth metatarsal within the tendon of the peroneus brevis muscle. Os tibiali externum medial to the tuberosity of the navicular within the tendon of the tibialis posterior muscle. Most important ones are the metatarsophalangeal joint of the hallux finger and interphalangeal sesamoid of the great toe. Polar angle is the angle between a line joining the highest point of the anterior process of the calcaneus and the highest point of the posterior articular facet, this line, and a line joining the highest point of the posterior articular facet with the highest point of the calcaneal tuberosity, this line. It is normally between 30 to 35 degrees with an angle less than 28 occurring in displaced intra-articular calcaneal fracture. In this radiograph, we see decreased polar angle, indicating intra-articular calcaneal fracture. Heel path measuring between the calcaneal tuberosity, posterior inferiorly, and the skin surface. Normal thickness are 21 mm in female and 23 mm in male. Thickening of the heel path occurs in patients with gigantism or acromegaly. So here we have lateral radiograph of the foot with a grossly enlarged and thickened calcaneal heel path. Although not pathognomonic, a heel path thickness greater than 23 mm may indicate acromegaly. This is the heel path thickness. Jones fracture through the styloid process of the base of the fifth metatarsal. This is the styloid process of the base of the fifth metatarsal. Should be differentiated from the oblique epiphyseal line. So here we have a fracture in this X-ray. We have fracture, Jones fracture, and we have oblique epiphyseal line. This is also Jones fracture. And thank you.
عاشت ايدك دكتور محمد. دكتورة خنساء أشر لهم على
تمام أستاذ.
بالبوريتر. نمبر 1 خنساء.
medial femoral condyle.
medial femoral condyle. عقيل. نمبر 2.
نعم أستاذ. intercondylar eminence.
intercondylar eminence. دعاء سعد.
نعم أستاذ. tibial femoral joint medial compartment.
من دعاء على.
نعم. tibial shaft. tibial shaft.
مشر مو على التيبيال شاف.
ايوه تيبيال تيبروستي.
تيبيال تيوبروسي بس هي من الفرونتال بين. ليندا.
نعم أستاذ. الفيبيولا.
نمبر 6 سالي عبد الرضا.
نعم أستاذ. الهيد أوف fibula.
رشا داخل. نمبر 7.
نعم أستاذ. نمبر 7 tibiofemoral joint proximal.
اكسلنت. هاي جوينت صحيح. رنين رفعت. نمبر 8.
Number 8 tibialofibular femoral lateral compartment joint.
جوينت سبيس. اكسلنت. شيماء علاء مكي. نمبر 9.
lateral femoral condyle.
lateral femoral. مريم خليل. نمبر 10.
نعم أستاذ. نمبر 10 patella.
ولاست 1 عمر فهمي.
نعم أستاذ. فيمر.
فيمر. اكسلنت. هسه اللاترال الاستاذ محمد تكمل وياه.
ويا استاذ محمد مهدي رقم 12.
نعم استاذ. الفابلة.
فابلة. نور رقم 13. نور بابا.
نعم أستاذ. رقم 13 tibial fibrosis.
تيبيال تيبروس. لارا رقم 14.
نعم أستاذ. femoral patellar joints.
زيد يوسف.
نعم أستاذ. The patella is a sesamoid bone within the quadriceps tendon. True.
زهراء صباح.
نعم أستاذ. The fibula is frequently found in the lateral head of gastrocnemius. صحيح. True.
صفا شامل.
Start. The shaft of femur ossified at the 35 weeks of fetal life. False. 7 weeks.
لارا.
نعم أستاذ. In bipartite patella, the superolateral part is separated to the rest of the patella. True.
علي حسين.
نعم أستاذ. The anteversion of the neck of the femur increases from childhood into adult life. False. Decreases.
Excellent.